Topic for today's lecture is chronic inflammation. Before going on to chronic inflammation per se, let's take a look at the fate of acute inflammation. And one of the fates of acute inflammation is that it goes on to chronic inflammation. If in acute inflammation the etiologic agent is removed, then and there has been minimal or no tissue loss, it will result in resolution or complete restoration to normal. If there is a slight tissue loss, mild, it will result in regeneration. And finally, with tissue loss, there will be healing by fibrosis. But in the other scenario, if there is persistence of the etiologic agent, which is not removed by acute inflammation due to any reason, then it can lead to a suppuration, and which is a purulent lesion and will form suppuration, which will ultimately either go on to chronic inflammation or will heal by fibrosis. In case there are recurrent bouts of inflammation due to this persistence of the etiologic agent, it will result in chronic inflammation. Let's take a look at one more schematic of the same thing. See, you can see from here that with acute inflammation can have four types of fates: 1, 2, 3, and 4. First, most commonly is resolution. Second, suppuration and pus formation. This will go on to heal. It can heal directly if the injury is bigger than what needs resolution. It will go on to healing by fibrosis. And the fourth is progression to the chronic inflammatory process. The chronic inflammatory process not always stems from acute inflammation. It can also stem directly from injury by viral infections, chronic infections, persistent injury, autoimmune diseases. And these are some of the features which are prominent in chronic inflammation, that is angiogenesis, mononuclear cell infiltrate, and fibrosis. We are going to look into the details of this. And finally, there is healing with slight loss, complete loss, or impairment of the function due to fibrosis. Now let's go on to chronic inflammation proper. The chronic inflammation is defined as inflammation of prolonged duration. So you need to have a long duration inflammatory process in progress, in which three processes are going on simultaneously. That is active inflammation, tissue destruction, and attempts at healing. All are going on simultaneously. Remember, this is not acute inflammation, it is active inflammation. Active inflammation and then subsequent tissue destruction and attempts at healing, all are going on simultaneously in this same time frame. Chronic inflammation, going into the details of how chronic inflammation can occur. It can follow acute inflammation, as we have seen, when it is extensive tissue destruction and bacteria survive and etiologic agent survives and persists in small numbers. The classic example is that of osteomyelitis and pneumonia terminating in lung abscess. Lung abscess is a chronic inflammatory process then. Then there can be recurrent attacks of acute inflammation, in which recurrent urinary tract infection, especially seen in females, leading to chronic pyelonephritis, and repeated acute infection of gallbladder, leading to chronic cholecystitis. This is a very common scenario. A patient gets acute infection of gallbladder manifesting as severe pain in the right hypochondrium or in the epigastrium, and then with painkillers and injectable or otherwise, the pain subsides. The attack is repeated on dietary indiscretions, excessive consumption of fats that cannot be digested, and this again leads to another acute attack. And these acute attacks keep on going on, and finally they culminate into chronic cholecystitis. What you see as a pathologist during microscopy when a gallbladder is removed for chronic cholecystitis is the thickening of the wall of the gallbladder. That is the surest sign that this is a specimen of chronic cholecystectomy. Then the third way that chronic inflammation can occur is starting de novo, as we saw in the previous schematic. When the infection with organisms of low pathogenicity takes place, infection with Mycobacterium tuberculosis, not only Mycobacterium tuberculosis, but Mycobacterium leprosy also, then some inert materials and all can also produce the same picture, chronic inflammation de novo. Now this is chronic inflammation widely taken as the causes, but it is specifying the de novo infection by organisms like TB bacillus, as we saw, Treponema pallidum causing syphilis, and most of the fungi result in chronic inflammation because they all are of low pathogenicity and produce a smoldering infection. Then, for prolonged exposure to potentially toxic agents like silica and plasma lipid components can also elicit chronic inflammation. Silica is a relatively inert substance but potentially toxic, so it leads to silicosis, which affects the lung, and this is especially seen in workers of silica mines. Then plasma lipid components, these are operative in case of atheromas where they abound and they cause chronic inflammation by persistence of their nature, and by nature they also, as we'll see later, they cause immobilization of the macrophages. The third is the immune reaction against self tissues, that is autoimmune disorders like rheumatoid arthritis, lupus erythematosus. This is what is also known as inflammation gone wrong. It harms the its own tissues. So that is an autoimmune disorder. The characteristic features, the three characteristic features which were included in the definition itself are presence of active inflammation, and this inflammation is by mononuclear cells. The macrophages, lymphocytes, plasma cells, and you can also add eosinophils to this because they may be actively seen during parasitic chronic inflammatory processes. The second component of the definition was the feature was tissue destruction, and third was attempted repair by connective tissue, which involves replacement by fibrosis and angiogenesis. Angiogenesis means formation of new blood vessels. The chronic inflammatory cells predominantly are macrophages, lymphocyte, plasma cells, and as I said in the previous slide also, eosinophils. Mast cells also have been proposed to be the cells of chronic inflammation, but by far the most important cell in these cases of chronic inflammation is the macrophage. The macrophage is the central cell, is the most important player in mounting a chronic inflammatory response. The mononuclear cell infiltration, in which, as we have already seen, macrophage is the most important cell of chronic inflammation. This macrophage is a part of MPS or RES. MPS stands for monocytic phagocytic system, monocyte phagocytic system, or the reticuloendothelial system. The major components of the MPS or RES are the blood monocytes and tissue macrophages, which are essentially the same cell, named differently depending on their location. The connective tissue abound in our body. The monocytes are found sprinkled liberally in connective tissue. Then they can be found in the form of Kupffer cells, that is the location is liver. The microglial cells, these are the macrophages present in the CNS. The sinus histiocytes are the macrophages present in the spleen and the lymph nodes. And as the name tells you, the alveolar macrophages are residents in the lung tissue. So these are all the areas where you can find lots of macrophages, and they are given different names in depending on their location. Now, in the marrow, what you get is the monoblast. Then from marrow, it passes into the blood and matures into a monocyte, where its life is 1 day. From there, it passes on to the tissues. From blood, the monocyte migrates into the tissues, where it is known as the macrophage, and it lives very long in the tissues, life as long as many months. So from marrow to blood to tissues, it changes from monoblast to monocyte to macrophage, and its lifespan being 1 day in the blood to many months in the tissues. Then we take a look when it appears. It appears after 48 hours of acute inflammation. The monocytes begin to predominate, replacing the neutrophils. And mechanism of their arrival and migration into the tissues is the same as was seen for acute inflammatory cells. That is, initial reaching the site of inflammation through the process of rolling, then adhesion, then pavementing, then transmigration, and then chemotaxis along a chemical gradient to reach the site of injury. And on reaching the site of injury, the macrophages become activated. The monocytes have migrated and they are now known as the macrophages. The macrophages get activated and phagocytic, which is their chief function that they are going to perform at the site of injury. The activation of macrophage is a very crucial process and goes through two major pathways, that is the classical pathway and alternate pathway. Here it would be useful to mention that these same terms, these pathway activations, are also found the classical pathway activation and alternate pathway activation in the complement system also, where we have another activation, and that is by the lectin pathway. Back to macrophage activation, they can be activated either classically, as we said, and alternatively. Classical activation is through microbes and interferon gamma, whereas alternate is through cytokines, that is interleukin 13 and interleukin 4. These produce, both of them are required during the chronic inflammatory process. The substances produced by classically activated macrophage include the reactive oxygen species, the nitric oxide, and the lysosomal enzymes, and also the cytokines, interleukins 1, 12, 23, chemokines, etc. Whereas the substances produced by the alternatively activated macrophages, or M2s, are the growth factors TGF beta, transforming growth factor beta, interleukin 10, and again transforming growth factor beta. There is an overlap between these two also, but these are the major production by the classically activated and the alternatively activated macrophages. Now, as we can see, what we need is chronic inflammatory process. The definition to be complete requires inflammation, requires phagocytosis, killing, that is destruction, and finally attempts at healing. And then finally, this is the regulatory effect also produced by the alternatively activated macrophages, is that of the anti-inflammatory effect, causing the cessation of the inflammatory process. So macrophage remains the central cell and the chief player in the process of chronic inflammation. So what does it show on activation? It shows increased cell size, increased lysosomal enzyme levels, increased metabolic activity, which leads to increased phagocytic and killing ability. All these lead to increased phagocytic and killing ability, and they secrete, as we have seen, several products which mediate tissue destruction and fibrosis. Let's take a look at what they are. Tissue destruction is mediated via toxic oxygen radicals, proteases, chemotactic factors, coagulation factors, arachidonic acid metabolites, and nitric oxide. These we saw, these are the chemical mediators, the arachidonic acid metabolites, the leukotrienes, and the lipoxins. The nitric oxide is another chemical mediator, toxic oxygen species, chemotactic factors, all contribute to tissue destruction. Whereas fibrosis is brought about by the growth factors like platelet-derived growth factor, fibrogenic growth factor, transforming growth factor beta, the fibrogenic cytokines. These are the cytokines that stimulate fibrosis. And finally, the collagenases. All these causes laying down and balance of collagen deposition. So this contributes to fibrosis. Then another question that should come to our mind is that why the macrophages persist and what are the mechanisms that help them to stay longer at the site of injury to produce their actions. The first mechanism is that there is continued recruitment of monocytes from circulation. And this is the most important mechanism. From blood, they keep on migrating to the site of injury and there is continuous recruitment. The second is that they proliferate locally at the site of injury. This is operative in the process of atheroma, where they get trapped into the plaque and the oxidized lipids and undergo local proliferation. And then this locally proliferated cells, they are immobilized also at the site of inflammation, again by oxidized lipids, added on by the MIF or the macrophage inhibiting factor. So this motility of the macrophage is neutralized at the site and therefore they remain immobilized at the site of inflammation. And two factors, MIF and oxidized lipids, contribute to this. So as we have seen, oxygen metabolites are toxic to cells. Proteases are toxic to ECM or the extracellular matrix. So these all contribute to tissue destruction. Inflammation, tissue destruction, and then cytokines bring about cell influx, the continued recruitment, and growth factors bring about repair. Fibroblastic proliferation and collagen deposition by growth factors. So all the criteria of chronic inflammation are met with by single cell alone, and that is the macrophage. All these actions are very useful, but they are responsible for lots of innocent bystander destruction of the tissues also. The normal tissues also undergo destruction. The other cells of chronic inflammation, the other players are lymphocyte, plasma cell, mast cells, and eosinophils. We'll just take a brief look at their role, but lymphocytes are slightly more important because they set up a cycle. A cycle is set up in which the activated macrophage stimulates the lymphocytes through the action of cytokines and antigen presentation and all, and the T lymphocyte gets activated, and this activated cell secretes several products like interleukin 17, interferon gamma, and leads to activation of the macrophage. So a cycle is set up in which the lymphocyte activates macrophage, macrophage in turn activates T lymphocyte, and this goes on till this chronic inflammatory process is continuing. And these, as we have already seen, they also, macrophages contribute again to leukocyte recruitment and inflammation, and these also contribute to inflammation indirectly by activating the macrophage and directly by secreting cytokines and tumor necrosis factors, which contribute further to the process of chronic inflammation. The other cells, the plasma cells, as we all know, are differentiated B lymphocytes which produce antibodies. Eosinophils are abundant in IgE-mediated immune reactions, as we said, in parasites, and the granules contain MBP, or the major basic protein, which is, as you remember, was talked about in the acute inflammatory process in the oxygen independent killing mechanism. It is one arrow in the armory, and that is major basic protein contributes to the killing or degradation by the oxygen independent mechanism. Mast cells are again derived from bone marrow, and they are large cells, mononuclear cells, and distributed mainly in the perivascular and perineural regions, found both in acute and chronic inflammation, release histamine, and binds to IgE. If you remember, in acute inflammation also, their role by releasing histamine was in increasing the vascular permeability by causing endothelial cell retraction and contraction. Then this again, taking a look, mononuclear cells we have already seen. These are producing various substances which lead to tissue destruction. And now let's take a look at the attempted repair by connective tissue. How does that take place? When there is persistent tissue destruction, which is a hallmark of chronic inflammation, both the parenchymal cells and stromal framework are damaged. So repair cannot take place solely by regeneration of parenchymal cells alone. Since both have been damaged, both have to be repaired. And this repair is usually by replacement with connective tissue and resulting in fibrosis and scarring, which are relatively acellular areas. Like filling the defect, like the rafu, supposing you have seen the tailors repairing their large torn gaps in shirts and all, that is fibrosis and scarring. Now, this fibrosis and scarring in our body is a very systematic and a stepwise procedure which is endowed with 4 components. The components are angiogenesis, migration and proliferation of fibroblasts, deposition of ECM, and finally remodeling or maturation, which is maturation and organization of fibrous tissue. So this is the sequence of events that take place when there is repair by connective tissue or fibrosis. First, there is laying down of blood vessels with accompanying migration and proliferation of fibroblasts. This results in the formation of granulation tissue. We'll come to this in a moment. But then after this, there is deposition of the extracellular matrix, and finally, whatever extracellular matrix has been deposited is trimmed off. It is matured, and the organization, systematic organization takes place, and finally, the end result is the fibrosis and scarring. Now, like I said, these two will constitute the granulation tissue, which consists of young fibroblasts because of migration and proliferation, and proliferating endothelial cells. This is known as angiogenesis, which signifies the budding from pre-existing vessels. In contrast to vasculogenesis. Vasculogenesis is laying down of the primitive vascular system at the time of development, and is mediated via factors like VEGF1 and 2, that is vascular endothelial growth factor. Whereas angiogenesis, the vessels are already existing, and from them there is budding, and this is known as new vessels are formed, and this is known as angiogenesis. Also remember that granulation tissue and granuloma are 2 different entities. We'll be coming to granuloma shortly, but remember they are 2 different entities. Now, some growth factors stimulate collagen synthesis and also the secretion of metalloproteinases, or more correctly, matrix metalloproteinases or MMPs. These are enzymes which degrade the ECM components. Like we saw in the previous slide, that the ultimate result comes when there is degradation also of the extra synthesized collagen, resulting into fine remodeling. So the net effect of remodeling is the net effect of synthesis versus degradation. Leads to remodeling, and the final scar that you see is a result of this remodeling. Hence, MMPs or matrix metalloproteinases are crucial for remodeling. But they can sometimes go on unchecked and produce again and exceed the synthesis and produce a wide defect. So they are kept in check by a system of TIMPs, tissue inhibitors of matrix metalloproteinases. They are known as TIMPs. Once the process of remodeling has been achieved satisfactorily, they come into action and inhibit the production of MMPs. Now, like I said, we are going on to one definite distinctive pattern of chronic inflammation, and that is granulomatous inflammation, which is again chronic inflammation in which the predominant cell type is an activated macrophage with a epithelial-like appearance, hence the name epithelioid, epithelial-like. And granulomatous inflammation is also characterized by being a circumscribed area. It is a circumscribed area enclosing mainly the epithelioid cells and also some other layers, and then it is known as a granuloma. The granuloma is characteristic of granulomatous inflammation. So, by definition, granuloma is a focal area of granulomatous inflammation consisting of microscopic aggregation of modified macrophages. These are the epithelioid cells which we were talking about. So again, the central cell, the macrophage gets modified but remains there. That is epithelioid cells. And giant cells. The giant cells are produced by fusion of several epithelioid cells surrounded by a collar of lymphocytes. And additionally, older granulomas show an enveloping ring of fibroblast and connective tissue. So this is the morphology of a granuloma. As you can see, these are the epithelioid cells. These are the giant cell. This is a multinuclear giant cell. These are the lymphocytes. So what is not shown here is the peripheral color of fibrosis, plus one more thing which is very characteristic, usually seen in the center, is the caseous necrosis of a tuberculous granuloma. This is the microscopic picture. Once there is, see, this is the color, this is the circumscribed area, hence it is a granuloma. Then these are the epithelioid cells. These are the lymphocytes. Now again, what you are not seeing here is a giant cell, and you are not seeing any necrosis. So this, in tuberculosis, the granuloma is known as a tubercle. So this is a hard tubercle. When it contains caseous necrosis, it is known as a soft tubercle. See, this is the another picture showing the presence of giant cell. This is a giant cell. This is a giant cell. These are the lymphocytes and the peripheral color of fibrosis here, and the epithelioid cells, and a small bit of necrosis here. Right? Now the epithelioid cell, like I said, it is a modified macrophage. It is characterized by pale pink granular cytoplasm, one, indistinct cell boundaries. The nucleus is vesicular, that is, it is less dense. And as I told you earlier, they fuse to form giant cells, which now becomes a large mass of cytoplasm with 20 or more nuclei arranged peripherally. Then it is known as Langhans, or haphazardly as a foreign body type. Peripherally means just like the necklace around the neck, the nuclei are arranged peripherally. or they are clustered together or haphazardly, then it is known as the foreign body type of epithelial giant cell. See, now this is a cytological image showing epithelial cells which are seen, the morphology is seen. What we said, it is elongated cell with indistinct cell boundaries and a pale pink nucleus, less dense staining. So all these features can be made out here. These are the lymphocytes for comparison, the small cells, these ones. This is the caseous necrosis that you can see in the background. Then the types of granulomas can be two types, as we are saying, foreign body type granuloma by relatively inert foreign bodies and immune granuloma. Now, immune granuloma also requires the presence of indigestible particles of organisms. Additionally, it requires T cell mediated immunity of the host to the inciting agent, and this results in the necrosis and formation of a immune granuloma. And the classic example is a tuberculous granuloma, in which T cell mediated immunity is seen against the tubercle bacilli. This is a prototype tuberculous granuloma of granulomatous inflammation, as I told you, known as tuberculin tuberculosis, characterized by presence of central caseous necrosis, which is rare in other granulomatous diseases. Now, the granulomatous inflammation can be seen in a number of settings, with bacterial infections, with parasitic infections, with fungal infections, inorganic metal or dust, with foreign bodies, and also unknown causes, as seen in sarcoidosis. The mechanism is not very well understood, and you can see a granulomatous inflammatory reaction in this. Then foreign body, suture material, breast prosthesis, vascular grafts, all can incite a foreign body type of granulomatous reaction. Again, these in a relatively inert material like silicon and berylliosis can result in this. Fungal infections, as I told you earlier, they abound. Histoplasma, blastomycosis, all these can result in parasites, bacteria, all these can result in formation of a granuloma, and they are examples of granulomatous inflammation. Then specific tests have to be carried out and clinical correlation has to be done to find out the cause of inciting agent for granuloma. Now let's take a look at the giant cells, the type of giant cells that we have been talking about. These two are the Langerhans type of giant cells with a horseshoe shaped configuration or a necklace around the neck configuration. This is horseshoe configuration. You can see the nuclei here or here or here, all are clustered like this. So this is a horseshoe shaped pattern and can be seen at one or both poles. This is Langerhans, and remember, it is not Langerhans, it is Langerhans. The other type of giant cell which we talked about was containing regular nuclei but scattered throughout the cytoplasm. These are known as the foreign body type of giant cells. Then we have the Tauton or Teuton, whatever you want to call it. These giant cells, these have the nuclei arranged in form of a ring surrounding a central area of cytoplasm, and the peripheral cytoplasm is usually vacuolated. The central is dense and the peripheral cytoplasm is vacuolated. Then this is a tumor giant cell containing hyperchromatic nuclei. You can compare the color with these hyperchromatic pleomorphic nuclei, variable in size and shape. See the shape of this one and size, and see contrast the small one here throughout the cytoplasm. So these are all the various types, common types of giant cells that you will encounter from time to time as students of pathology. The morphological patterns of inflammation, that chronic inflammation that can be seen morphologically, that you see that as like the patient will come to you, will be serous, can be fibrinous, can be suppurative, can be ulcerative. It is dependent on several factors of what is being going will be produced, like the cause of the inflammation, the severity of the inflammation, the duration, the site, the tissue involved, and the immune status. Several factors come into play, but ultimately you see one of these four patterns. The serous, this is characterized by, as the name indicates, thin fluid, which is derived from either serum or from irritation to the mesothelial cells. The classic example is that of skin blisters due to burns or viral infection. See, this is the blister that you can see on this finger, and this is the microscopic appearance just below the skin. This is clear area, this was serous fluid here, right? Then next was fibrinous. In this, more severe injury is involved as compared to serous reaction. This is characterized by the presence of fibrinous exudate, which develops due to large vascular leaks. So the classic examples are body cavity inflammation like pleura and pericardium. And microscopically, what you will see is that the fibrin in form of eosinophilic meshwork or an amorphous coagulum in which cells may be trapped. This is removed by fibrinolysis, and this process is known as resolution. But in case it is not removed and there is growth of fibroblasts over it forming the meshwork and blood vessels, then it is known as organization. So the fibrinous inflammation can undergo resolution or organization. It has two fates. See, this is the classic example of fibrinous pericarditis. You can see this is the normal muscle here, but this is the fibrin meshwork in which this at the top, in which cells are trapped. Then the third morphological pattern that you might encounter is suppurative, or as the name indicates, purulent, characterized by presence of large amounts of pus. The pus consists of neutrophils, necrotic cells, and edema fluid, and debris also. The acute suppurative appendicitis is a classic example. While talking about this, we should also know what is an abscess. These are focal, localized collections of purulent inflammatory material. This pus. The pus then gets localized, buried in deep tissue, organ, or confined space. It is known as an abscess or an abscess. And once you drain out that pus, it is known as abscess cavity. This is purulent inflammation. You can see all these inflammatory cells. These are also the same thing. You can see this here, necrotic debris. Then the ulcer. This ulcer is a local defect or excavation of the surface of an organ or tissue. And this is due to sloughing off of the necrotic inflammatory tissue. It consists of the mucosa of oral cavity, stomach, intestine are classic examples, and sometimes in the subcutaneous areas of lower limbs due to circulatory defect. But it is a punched out area which you can immediately see. See, this is the oral cavity mucosa. These are the teeth that you can see here. This is the ulcerated area. You can see the gap and cavity. Now, systemic effects of inflammation are also there because the proteins are being released everywhere and the process is going on. So, fever will be produced due to cytokines. The prostaglandins and hypothalamus are produced, so they lead to fever. Then the acute phase proteins like ESR and in our current scenario, serum ferritin and CRP or the C-reactive proteins were used. So they are the acute phase proteins which point towards the presence of some reaction going on in the body. Then there will be leukocytosis, and in severe cases, septic shock can take place. Then going on from chronic inflammation, we go on to wound healing. Wound healing, like we said, it is closely intertwined with the process of inflammation. Healing by common consensus or by popularity is known as repair. But technically speaking, healing and repair are not synonymous. healing consists of two processes. It can be regeneration and repair. That constitutes either regeneration or repair. But broadly speaking, in common layman term, we use the term repair for healing in general. But as students of pathology, we ought to know that healing is of two types: the primary union or healing by first intention, and secondary union or healing by second intention or secondary union. Now, primary healing, as we see, is seen in clean, uninfected surgical incisions. So the wound needs to be clean with clear-cut edges and has to be uninfected. So this is a surgical incision, is no better example than surgical incision can be seen. So it is very important to remember this, because primary healing will occur only in this setting. The narrow incisional space that is there is filled initially with clotted blood containing fibrin and the RBCs, or all cells, fibrin and blood cells. So that is clotted blood, so it fills initially the incisional space. Then within 24 hours, what happens is that neutrophils appear at the margins and move towards the fibrin clot in the incisional space. And also at the same time, the epidermis starts thickening at the edge due to mitotic activity of the basal cells. So now the edges are active, neutrophils from the margins have started moving towards the fibrin clot, and the epidermis at the edge is beginning to thicken up. Then the 24 to 48 hours, in 1 to 2 days, that is 1 to 2 days, the spurs of epithelial cells, those that were thickening, now the epithelial cells from the edges, they both do two activities. They migrate and grow along the cut edges. They migrate as well as grow along the cut edges. And finally, they fuse in the midline to form a thin epithelial layer in the wound. So they fuse in the midline after growing along it. Then on the third day, what happens is that, as we have already seen in chronic inflammation, after 24 to 48 hours, the neutrophils are replaced by macrophages. So this is what happens here also. The neutrophils are replaced by macrophages. And simultaneously, granulation tissue invades the incisional space. It begins to invade the incisional space. Now the collagen fibers appear at the edges and epithelial cell proliferation continues, because we have to restore it to normal thickness. And then on day 5, the incisional space gets completely filled with granulation tissue. And granulation tissue, as you know, is neovascularization plus fibrogenesis. So neovascularization is maximal at this point. And collagen fibrils also become abundant and begin to fill the gap. And epidermis, which was proliferating, now recovers normal thickness and differentiation. Then by second week, there is continued accumulation of collagen and fibroblastic proliferation depending on the requirements, but leukocytes, edema, and increased vascularity all disappear. They all disappear. And end of first month, what you see, a scar is formed composed of cellular connective tissue devoid of inflammatory infiltrate. And this is covered with intact epidermis, which had already achieved its full thickness. The tensile strength of wound increases gradually, but it takes several months to attain maximal strength. And maximal strength, remember, does not mean that it achieves the full strength pre-injury. It might not achieve that. That was healing by first intention. Now coming to healing by second intention. This occurs in a setting where there is more extensive loss of cells and tissues. Then the reparative process, healing is by second intention, and reparative process is more complicated. It becomes quite complicated because large tissue defects need to be filled. And regeneration by parenchymal cells and slight collagen proliferation are not going to bring about reconstitution. Now, abundant granulation tissue grows into the edges to complete the repair. So then it is known as secondary union. Let's take a look. What are the features that you will see? You will see that the inflammatory reaction is more intense. Much larger amounts of granulation tissues are formed, and there is wound contraction. Why? Wound contraction is because of the myofibrillar fibroblast deposition. The myofibrils pull down the wound, the epidermis, and so that there is a contraction. And this wound contraction is one feature that differentiates after every healing has taken place between primary and secondary healing. This is a major difference which you can see grossly. Now, what are the steps of healing by second intention? The steps are: first, there is acute inflammatory response and regeneration of parenchymal cells and connective tissue cells, which then migrate and proliferate. Both parenchymal and connective tissue cells both migrate and proliferate, followed by ECM protein synthesis, because this also has to be deposited there. And finally, as we had seen during chronic inflammation, there is remodeling of both parenchymal and connective tissue elements, producing a scar or filled defect by collagenization. And finally, there is acquisition of the wound strength. So if you have paid attention to the part in chronic inflammation, you will realize that there's a lot of overlap between the chronic inflammatory process where attempts at healing are going on. So that healing is usually by second intention. Now the final outcome of the scar that is going to form is between, again, collagen synthesis and the breakdown, and breakdown is especially important and most useful in remodeling. Wound strength by first week is 10%, by third month it is 70 to 80%. And like I said, it may not grow beyond this and may remain at this level lifelong. So if you gain 70 to 80% of your wound strength, it is enough. Now there can be some factors which can adversely affect the process of healing. So these are, first, as we know, nutrition. If there is protein deficiency, the inflammatory process and the healing process will be hampered. Vitamin A deficiency will again inhibit collagen synthesis and retard healing. It also inhibits epithelial maturations. So vitamin A is very important for proper healing to take place. Then another agent that hampers healing are the glucocorticoids, which are anti-inflammatories, and therefore naturally they affect all levels of inflammation and the subsequent process of repair. Now, third is the infection. Again, it delays healing. Mechanical factors like increased abdominal pressure leading to burst abdomen. What is burst abdomen? In burst abdomen, what happens is that if a patient has undergone laparotomy and you have sutured up the abdomen in the center, now there is some factor which is producing an increased pressure increasing in the abdominal cavity. It will cause the suture to break open. That is known as burst abdomen. So again, healing has been delayed. The other factor crucial to healing is inadequate blood supply, because no cells will reach the site, so there won't be any. Consequently, as we said, in the process of inflammation in the definition itself, then an intact blood supply with adequate circulation is the key factor for mounting an inflammatory response and also healing. Then presence of foreign body again hamper healing, like suture material, steel and glass fragments. They will evoke a giant cell reaction and hamper healing. So these are the factors that affect healing. Then there can be some aberrations of healing. Aberrations. There were three components which we saw, that there is collagen deposition, there is granulation tissue formation, and there is fibroblastic proliferation. If any of these three elements goes out of line, there's going to be an aberration of healing. So first is keloid. In this, there is excessive collagen deposition. So it produces a raised tumorous scar. The next is, which resembles keloid, but it's slightly different in the fact that it is caused by excessive granulation tissue formation, and this is known as exuberant granulation, or more likely in the local jargon as proud flesh. In colloquial English, it is known as proud flesh. It protrudes above the surface, as does keloid, but keloid has a more ominous appearance. Then, if there is exuberant fibroblastic proliferation, if there is exuberant fibroblastic proliferation, it will lead to formation of desmoid, what is known as desmoid tumor. So, keloid due to excessive collagen, exuberant granulation or proud flesh due to excessive granulation tissue, and desmoid due to exuberant fibroblastic proliferation. Then, as we all know, bone is a special tissue which is often subject to trauma and fractures and has to undergo healing. So the fracture healing is a specialized type of healing, although the process remains the same, the basics remain the same, but it has slight differences, and it is important for a student of pathology to know those differences. So this usually occurs by callus formation mostly. The process is the same, either there can be a primary union or a secondary union. But in fractures, secondary union is more common. What type of repair will take place is again dependent on some features, whether the fracture is traumatic or pathological. Anything other than traumatic without a known traumatic factor or without any precipitating factor, if a fracture is taking place, it is known as pathological fracture. Whether the fracture is simple, both ends opposed, here there is usually chance of healing of primary union. Then compound and comminuted fractures, depending on how many fragments have been there, whether it is protruding out through the skin or not. So that depends on the situation, whether it will heal by primary union or secondary union. Now, as you can see, the primary fracture healing occurs when the fracture ends are approximated. They are not moved. There has been a simple crack, and union is by formation of medullary callus. There is no periosteal callus formation. Just a medullary callus is found and repair takes place. All you need to do is to immobilize the tissue. Healing is normally a natural process. But now secondary union, this secondary union is more commonly seen, and this is best described in 3 stages. First is the procallus formation, which has got 4 steps to it, which we'll see in detail. The second is osseous callus formation, and the third is remodeling. So procallus, osseous callus, and remodeling, with procallus involving the hematoma, local inflammatory response, granulation tissue ingrowth, and woven bone cartilage callus. If you recall, all these are somewhat similar to the steps of secondary healing in other tissues, which we have seen in the previous slides. Now the procallus formation, the first step that takes place once there is a fracture, which is not simple, which is not going to heal by primary union, is that a hematoma forms. The lots of blood vessels are torn, which fill the area, fractured area. So this hematoma is formed, which consists of blood and fibrin. And what do? They form a loose meshwork on which granulation tissue will form. And then naturally there is going to be a local inflammatory response. We know whenever there is injury, it is the response that is inflammation. So there is exudation of fibrin by increased vascular permeability, neutrophils and macrophages all come there. Now again, the macrophages, what they do, they clear away the RBC, fibrin, debris exuded, and additionally dead bone. But to help in clearing of dead bone, we have another set of cells. These are the osteoclasts. Again, multinucleated cells, which help in clearing the dead bone specifically. See, this is the healing of fracture. This is the medullary cavity. This is the fracture site, and this is the compact bone. So this is hematoma, which is filling the gap. Now everything will take place here itself. The next step we have seen is the influx of the inflammatory cells. Then there is going to be a growth of the granulation tissue. So it will be characterized by neovascularization, the proliferation of mesenchymal cells. From this is the variation because the tissue is bony from periosteum and endosteum. There will be proliferation of mesenchymal cells, and this will result in what is known as a soft tissue callus. So you see, this will form a soft tissue callus here. What will it do? It will cause the joining of both the ends of bone, but not without much strength. It will be without much strength. With the fracture ends will now be joined, but they will not have any strength. The joint doesn't have any strength. This is a soft tissue callus. Then finally, we have a woven bone of callus of woven bone and cartilage. Now, since these tissues are inherent to the bone, they have to be there. The cells of inner layer of periosteum, they lay down collagen and osteoid matrix in the granulation tissue. As we have seen, the granulation tissue was laid down and a soft tissue callus was formed. Now the cells of inner layer of periosteum in that lay down collagen and osteoid matrix. This undergoes calcification and is now known as the woven bone callus. Now this woven bone callus is far excess of what is required. Far in excess of what is required. So what we had seen in chronic inflammation, it has by second unit, healing by second intention was that there will be remodeling. So that will also take place here. But initially this gets a fusiform appearance, swelling on both sides. The procallus is arbitrarily divided into external, intermediate, and internal procallus. The external, intermediate, and internal procallus, we'll later on see what is the fate of all these three. Now, the second step, this was procallus formation. So it has resulted in the formation of a woven bone callus, right? Procallus, the woven bone callus. Now, this is to be replaced by osseous callus formation. This is of lamellar bone, so it is formed on the procallus or woven bone. The woven bone is cleared away by osteoclast again. And whatever calcium cartilage was deposited, it disintegrates. Now all this has been removed. So what will happen for lamellar bone to form? It is replaced by new blood vessels and osteoid, now this time by osteoblasts. This gets calcified, lamellar bone is formed, development of Evershian system takes place. The third is, we had said, remodeling. Now, since both osteoclast and osteoblast are active during lamellar bone formation. So blasts are laying down bone, the clasts are removing the excess bone. So removal of excess bone gives shape, gives the proper shape to the bone, and this results in remodeling. Now, as we had seen, the procallus was arbitrarily divided into three. So the external callus gets cleared away, the intermediate callus forms compact bone or contracts, and the internal callus differentiates into bone marrow cavity formation. So external callus is cleared away, intermediate forms compact bone, and internal callus bone marrow cavity. So this is a schematic showing the hematoma formation, the entire process in one diagram. Hematoma formation, granulation tissue, ingrowth of granulation tissue and inflammatory response, the procallus formation, all these steps, and the osseous callus formation. And finally, now you see this fusiform appearance, it is finally remodeled into the bone, achieving as much normalcy as possible in shape and function as well. Just a brief reminder of what types of bone we have been talking about. The lamellar bone and the woven bone is also known as the non-lamellar bone. In this, the major difference is that the collagen fibers are arranged in parallel systematically layers, whereas these are randomly oriented collagen fibers and they are seen during fracture healing. This is the lamellar bone. Osteocytes, osteons communicate with medullary cavity through Wolfman canals and all. And this is again the same cortical compact bone, the Haversian system that we were talking about. The periosteum is here and the cement lines are here, right? The woven bone, as you can see, haphazard laying down pores, random orientation, haphazard laying down of collagen fibers, much weaker than lamellar bone. Now this is remodeled into the lamellar bone. Now, if there is healing, there can sometimes be complications in this healing process, and they can be pertaining to union only. So the union can be fibrous union, there can be non-union, or there can be delayed union, depending on different settings. What can they be? Usually they are due to, all this occurs due to improper immobilization. And so if in this there is improper immobilization and fibrous, finally the callus is not formed, it will form a false joint at the fracture site. This is also known as pseudoarthrosis. If there is non-union, this occurs when there is soft tissue interposed in between the fractured ends, not being properly aligned. And delayed union can occur again due to the factors which lead to either improper mounting of the inflammatory response, or the healing process can be infection, malnutrition, old age, reduced blood supply, movement. Again, this is improper immobilization, and this is the most common cause of all these complications is improper immobilization. So we have taken a brief look at the chronic inflammation and wound healing. Now I have some questions for you, and it will help you in revising as well as paving the way for your examination. I'll give you the answers as well in the following slides, but all are Celsus signs of inflammation except, so as you can see, these are the classical signs given by Celsus were 4. The cardinal signs of inflammation were rubor, calor, dolor, and tumor. So what is missing? This is the odd man out. Cyanosis is not a part of the cardinal signs. Pain, swelling, redness, and what else? Rubor, redness, calor is missing, that is heat. Tumor is swelling, and dolor is pain. So the correct answer is C, right? Then the next question is, rubor or redness and inflammation is due to dilatation of arterioles, increased vascular permeability, increased viscosity of blood, and edema. So the answer should be A, dilatation of the arterioles. Sequence of events in acute inflammation, which we had talked about in our lecture, is vasodilatation. No, it starts with vasoconstriction. So transient vasoconstriction, you should focus here. So all three are showing transient vasoconstriction, followed by persistent vasodilatation, right? But this stasis here, so this rules it out. This is followed by vasodilatation, followed by stasis, followed by increased permeability. So this should be the correct answer, and that is transient vasoconstriction, vasodilatation, increased permeability. No, this is incorrect. The answer is C. First to appear in acute inflammation is C, vasoconstriction, C. All of the following vascular changes are observed in acute inflammation except vasodilatation, stasis, increased vascular permeability, the decreased hydrostatic pressure, it is increased hydrostatic pressure. Most characteristic feature of acute inflammation is vasoconstriction, vascular stasis, vasodilatation, and increased vascular permeability. and margination of leukocytes. Following host tissue responses can be seen in acute inflammation except exudation, vasodilatation, margination, and granuloma formation. These are some of the questions are of recall, some are of logical reasoning, so you can take a look at them correctly. They are being offered for teaching purposes to you. Correct sequence in extravasation of leukocytes is margination, rolling, adhesion, and transmigration. So this is the correct answer. Now, leukocyte migration through capillary wall is called diapedesis. Diapedesis primarily occurs in venules, all of which are family of selectin except A-selectin is no entity. True about integrin is used in binding, oncogene, anti-oncogene component of basement membrane, used in binding. Earliest transient change following tissue injury will be neutrophilia. So these are some of the questions which we'll be giving to you. You can go through them and answers are being provided and you can revise your topic through these, and if there is any difficulty you can contact us.